regarding pericarditis. It is nothing but inflammation of pericardium. Pericardium. The heart is surrounded by two layers of pericardium. One is the parietal and another one is the visceral, which are supplied by a fluid which is nothing but an ultrafiltrate from the plasma. It is usually around 15 to 50 ml. The main functions of this pericardium are it prevents the cardiac enlargement during hypervolemia, particularly the right atrium and right ventricle, and protects the heart from getting infected from the adjacent structures like pleura and mediastinum, and also keeps the heart in position. Coming to the classification of the acute pericarditis, clinically it is divided into acute, subacute and chronic depending upon the duration. Less than 6 weeks it is acute, 6 weeks to 6 months it is subacute, and more than 6 months it is chronic. Coming to the etiologic classification, it is classified into infectious, non-infectious, immune mediated and miscellaneous. In the infectious pericarditis, viral, bacterial, tuberculous, fungus and other infections can contribute to acute pericarditis. And in the non-infectious pericarditis, it could be idiopathic, it can be related to uremia, that is renal failure, and neoplastic, both primary as well as metastatic. Metastatic tumor, remember, lung and breast, lymphoma and leukemia are the four tumors that can metastasize to pericardium. Both penetrating as well as non-penetrating trauma, acute MI, post-irradiation and metabolic causes like myxedema and hypercholesterolemia. Pericarditis presumably related to hypersensitivity to autoimmunity. It is seen in rheumatic fever and some connective tissue disorders like SLE, rheumatoid arthritis, ankylosing spondylitis, scleroderma, and drug induced in the form of hydralazine, phenytoin, isoniazid, minoxidil, methotrexate, etc. Remember, methotrexate causes mitral stenosis. And post cardiac injury in the form of post pericardiotomy, post traumatic and post myocardial infarction, which is called as Dressler syndrome. These are the etiologists began classification of the pericarditis. Coming to the clinical features, the typical patient will present to us with chest pain, which is retrosternal, left-sided, can radiate to neck, arm and shoulder, which mimics MI, and this pain typically gets aggravated on assuming an supine position, that is on lying down the pain gets aggravated, and the pain gets typically relieved on sitting up and leaning forwards. This pain radiates to trapezius ridge and can be pleuritic also sometimes due to concomitant pleural involvement. Mostly the pericarditis patient will be having pain, but only in 4 conditions we will get painless pericarditis. Those are tuberculous pericarditis, uremic, neoplastic and post-irradiation, because these are chronic condition where pain will be absent, can be absent also. And patient can have elevated enzymes also. The cardiac troponin and CPKMB can also be elevated because of the concomitant epicardial surface involvement. But this magnitude will be very less when compared to the MI. So in total, this condition mimics MI because of the chest pain, enzymes, as well as the ECG chest. Patient can have ST elevation also. Coming to the clinical finding, patient will have a frictional rub which is triphasic, that is murmur will be had in 3 phases, 1 component in the systolic and 2 in the diastolic components. It is better heard with the patient sitting and leaning forwards with the breath held in expiration. ECG of the patient with pericarditis goes through 4 stages, 1, 2, 3 and 4. In 1, there will be diffuse ST elevation, it is concave upwards. Remember, in MI it is convex upwards. Concave upwards ST elevation diffusely with the ST depression in AVR and B1. This is the first stage. And second stage, the ST elevation went up, comes to normal. And third stage, T wave goes in for inversion. And fourth stage, T wave becomes normal. In addition, patient can have PR depression due to atrial involvement and electrical alternans if the patient has developed effusion. You can see that the patient has PR diffuse ST elevation here in lead 1, lead 2. In almost all the leads, the patient has ST elevation, and remember this ST elevation is typically concave upwards. Concave upwards, that is U-shaped. Whereas in MI it will be convex upwards. And electrical alternans, see here, the QRS complexes are taller and shorter in alternating bits, which indicates electrical alternance. This is seen if the patient has developed pericardial effusion. And yet another condition where we'll get diffuse ST elevation, can get diffuse ST elevation is benign early repolarization, though they are more common in the pericardial leads. The differentiating point between these two, the important one is the ST-T ratio, that is the magnitude of the ST elevation to the T wave. If it is more than 0.25, it indicates pericarditis. In the second ECG, you can see that the ratio between ST elevation to T wave is more than 0.25, which favors pericarditis. Whereas here, the ST ratio will be less than 0.25, which indicates benign early repolarization. Pericardial effusion, if the patient develops pericardial effusion, patient will show electrical alternance, muffled heart sounds, and EVAT sign can be demonstrated, which is nothing but atelectasis of the left lower zone of the lungs due to compression by the pericardial effusion, where the patient will be having findings similar to consultation, that is dullness on percussion and bronchophony on auscultation. Diagnosis, 2D echo can diagnose your pericardial effusion. And management, it is managed, pain is typically managed with aspirin and other NSAIDs. Colchicine can be tried because it inhibits neutrophil migration to the site of inflammation. The dose is 0.5 mg OD if the patient weighs less than 70 and 0.5 mg BD if the patient weighs more than 70 kg. It is contraindicated in liver and renal diseases. GI symptoms, particularly diarrhea is one of the side effects of colchicine. If the patient develops diarrhea, the colchicine has to be stopped. And steroids can be tried, but the full dose should be given only for 1 to 2 days. Then it has to be tapered due to the fear of recurrences. In case of recurrent conditions, we can go for azathioprine, anakinra, interleukin 1 antagonist, and pericardial stripping.